pain treatment using catheter or ultrasound. And this is our first paper for JVIR about this pain treatment about tendinopathy and cystopathy. Tendinopathy and cystopathy contains the tendinocerebral or jumper's knee or Achilles tendinopathy, something. It's very common and it's sometimes hard to manage. So let me give you one example. This is 75 years old female who have 1 year history of heel pain and diagnosed as plantar fasciitis and refractory to standard treatment, including rest, physical treatment, and painkiller. So this is affected area. And this is a normal angiography of from the posterior tibia. This is a normal angiography. This is normal appearance, but compared to the normal appearance, this is an angiography of the present case. Maybe you cannot see it smoothly. The movie doesn't move smoothly, but you can see the abnormal increased blood vessels like this here. Yeah. So this is inflammation induced newly blood vessels. This one. And the catheter tip. Catheter is inserted from the groin to this area, foot joint, and we can see the inflammatory vessels here. And from here, we infuse the particle, temporary embolic particle, that can be resolvable in normal artery, but cannot embolize inflammatory vessels. First temporary embolic material we use was imipenem. This is antibiotics and crystalline compound and antibiotic and slightly soluble to water. So this particle can embolize in the microvessels, inflammatory microvessels, but quickly recanalize in a normal vasculature. This is a movie. Of this particle flushed out in the contrast. You can see the particle is sometimes aggregate. Can you see this movie? I'm not sure you can see this movie or not, but yeah. And this movie, the left side is particle. The imipenem particle goes through the normal artery and dissolve in a few minutes. But this particle dissolves within a few minutes in a normal arteries, but right side is inflammatory tissue. In the inflammatory tissue, we can see the many particles did not resolve after more than 90 minutes. So we use this temporary embolic material. This is a temporary embolic material, and the left is before embolization, and the right is after embolization angiography. And you can see the inflammatory nerve vessels disappear, and at the same time, the normal blood flow increase. So, and this blue line means change of pain VAS score, pain score And before this procedure, the patients have a severe pain, and after this procedure, patient's pain decreased within 3 months, and the pain zero maintained a long time. So, T.A.M.E is a technique aimed at reducing inflammatory vessels and leading normal blood flow. That is the concept of this procedure. Okay. And now the most accepted procedure of this field is genicular artery embolization. Genicular artery embolization is a procedure for reducing the inflammation by blocking inflammatory vessels in genicular artery. Genicular is a knee, so the knee osteoarthritis embolization treatment. So this is a geography of knee joint, and we can see the lots of inflammatory vessels, and after the infusion of temporary embolic material, we can see the reduction of inflammatory vessels. So the GAE is now most studies non-controlled cohort studied, and the current evidence is the GAE is reported as a safe procedure, and the responders 70% experience a dramatic reduction and improvement in function within the first 3 months. The benefit is maintained to midterm follow-up. So this procedure is widely performed in United States and, for example, Europe, including the Germany or Spanish or French, and also your country, India. And Dr. Banker have performed lots of many cases of T.A.M.E. And this is a meta-analysis paper of 11 studies, including more than 200 cases of GAE, and result they reported the procedure is very safe. Sorry, and this is just a moment. This is an MRI of the patients of knee joint. This is a knee joint MRI, and we can see the inflammation in the medial side. So patients have medial knee pain, and we can see the medial side inflammation like this. And we perform angiography, and we can see the inflammatory neovessels like here, and infusion of embolic material, and after that we can see the inflammation vessels disappear, and this procedure works well, and she suffered from the many years of knee pain, medial knee pain, and improved and maintained a good condition for more than several years. So I will skip this data. Next, I will talk about embolic material in use of T.A.M.E procedure. We have several types of embolic material. First is a permanent microsphere. Permanent microsphere maintained inside the blood vessels for a long time, 2 months or 3 months. So we call it an embosphere or embossing. A PVA is a relatively a longer time, permanent microsphere. The lower one is a temporary embolic material. Imipenem, just I introduced you, and the next sphere is made by 𝐶, sphere type, and 𝐼𝙧𝙪𝙧𝙯. 𝐼𝙧𝙪𝙧𝙯 is a liquid embolic materials and others. And basically, the permanent microsphere have a side effect like cutaneous skin damage and nerve damage and pain, strong pain after embolization. So we recommend you to start with a temporary embolic material. Next sphere F is one type of temporary embolic material. This is a bottle, the picture of bottle. This is a sphere type. This is a microscopic finding of this particle. The size is around 200 or 300, and you can see the sphere type and made by Zerachin. This particle is this graph shows diameter of this particle. You can see the 100 to 500 diameter of particle, and also this graph means the reduction of volume. So this particle reduced their volume by 50% in 2 hours. So it means that this particle dissolvable one, and which can temporary embolic, which can have a temporary embolic effect. So we have conducted a comparative study within the 𝐸𝐸 and the 𝑁XPRF and compared the clinical results. And safety data was very similar. Usually, the permanent microsphere has 10% risk of numbness or muscle, sometimes cutaneous skin damage and strong pain, but these 𝐸𝐸 and the 𝑁XPRF both are very safe, low risk of pain after embolization, and also there was no risk of numbness or skin damage or muscle weakness. And this is a figure of duration of post-embolization pain, and we notice that elbow joint is the only joint who has a specific character. We have to be careful not to infuse too much for the elbow joint, because elbow joint is the weakest joint for the ischemic event. So when we treat the TENS elbow or Golfer's elbow, we are very careful not to infuse too much amount of 𝐸𝐸 or 𝑁XPRF. So, and this clinical 𝐸𝐸 and 𝑁XPRF have similar results, but especially in the TENS elbow or jumper's knee, the 𝑁XPRF have better results compared to 𝐸𝐸. Knee joint, the results is similar. And frozen shoulder, the 𝐸𝐸 was better, but in the TENS elbow or sports injury, the 𝑁XPRF demonstrated better results. And our mean VS score reduction from baseline at 3 months of treatment was around 40. This was similar in the reported proved mean difference between the baseline to 3 months. Reported one was 40. So the independent results and the 𝑁XPRF results is similar to the permanent microsphere in the knee joint, knee osteoarthritis. But this particle has a safer character for this treatment. Sorry, I will skip this data. And the next, I will talk about the good indication of this procedure. One is a knee osteoarthritis, and the second is a frozen shoulder. And third one is the tendinopathy or encephalopathy, or we can also say sports injuries, like TENS elbow, jumper's knee, Achilles tendinopathy, plantar fasciitis, and proximal hamstring tendinopathy. So TENS elbow is a very common cause of elbow pain. There are lots of patients who do not have good results from a conservative treatment like steroid injection or PRP injection or rehabilitation. Patellar tendinopathy is also called a jumper's knee, and this is also difficult to management. But embolization procedure is a good treatment option for this treatment, for this condition. And Achilles tendinopathy is also very common, and we can treat by embolization. And plantar fasciitis is a common cause of heel pain, and proximal hamstring tendinopathy is a common cause for the hip pain. So first, I'd like to talk about patient selection. So we basically, all patients are evaluated by MRI and ultrasound, primarily to embolization procedure to confirm the presence of hypervascular region. Hypervascular region means sickness or effusion or edema or increased color of the signal or contrast enhanced. So we usually use ultrasound in the tensor or jumpers knee Achilles tendinitis or appendicitis. And we use MRI for proximal hamstring technology. This is ultrasound imaging of patella tendon thickness more than 7 millimeter is the indication, and also increased part of the signal. The plantar fascia thickness larger than 4 millimeter is a good indication for this procedure. So for the patient selection, it's important to the diagnosis. Imaging diagnosis is very important. And in the proximal hamstring tendinopathy, we use MRI, and we can see the effusion around the tendon and a higher intensity of bone marrow and intensity peritendon higher intensity is very important for the diagnosis, and these patients are good indication for embolization treatment. I will skip this, but we sometimes use ultrasound, sometimes use MRI for patient selection, like this. And I will briefly introduce our recent paper that is describing the genicular artery embolization for the patella tendinopathy for 7 years follow-up. The patella tendon is located under the infrapatellar, and we can see the abnormal vessels like this. And after embolization, we can see the decreased disappearance of abnormal vessels. We use a independent for 53 cases. We use an XPRF for 33 cases and compare. I'm not sure you can see this, but this is a movie during the procedure. The catheter is inserted from groin, and the microcatheter is inserted into the inferior lateral genicular artery, like this. And we perform the angiography from here. This is angiography, and we can see the brush in here. And we change the direction from AP view to lateral view. And this is a lateral view angiography. You can easily see the abnormal brush here. And after that, we will prepare the temporary embolic material. This time is the next layer, and put small amount and the saline flash and repeat it until the brush disappears. So now we infusing the next BIF embolic material, and we perform the angiography again. We can see the decrease or disappear of blood vessels, inflammatory blood vessels. So after doing that, the complication rate was very low, and the clinical results, the both independent and the next BIF demonstrating the reduction of pain score like 1 month, 3 months, and 6 months, and the final follow-up like this. And we compare the independent and next pair, and the next pair has a larger amount of pain reduction. And we will also check the safety of tendon, because some treatment can induce a tendon rupture, but our treatment, we have treated more than 800 cases of plantar fascia Achilles tendinitis, but no one has resulted in a ruptured tendon. This is very different from the steroid injection data. Steroid injection results 3 to 10% of rate of tendon tear. So it can be said that our treatment is safer for the tendon rupture compared to steroid injection. So I will show you this case is a Japanese top level runner, female runner, long distance runner, and he has a 1 year history of left hamstring injury, and we can see the higher intensity area of this area, and this is a coronal MRI, and we have performed angiography. We can see the brush from the inferior gluteal artery or obturator artery. So we performed an embolization from here, and he returned to sports activity for the 3 months later, and now maintained a good condition. And finally, I will introduce our new technique, not using catheter, but using only ultrasound imaging. Plantar fasciitis is our good indication, and the target artery is from the posterior tibial artery. And this year, we have published the paper to the foot and ankle surgery that our ultrasound guided simplified pain procedure. This procedure is not using a catheter, but directly punctures the posterior tibial artery and infusing the lymphadenum. Like this. This is a movie of this procedure. You can see the ultrasound, and you can see the posterior tibial artery, short axis of posterior tibial artery, like here. And after that, we will puncture this artery by using 25 or 27 gauge needle under ultrasound. Now, maybe you can see our needle tip is located inside the artery, and you can see the particle is now infused in this area, and after that, doing the small time of manual compression for the 1 minute or 2 minutes and finish. So this procedure is very short and it only takes 1 minute or 2 minutes, but we can do the embolization procedure, not using fluoroscopy or angiography catheter or machine, but only use ultrasound, and we can do in the consultation room. After this procedure, the patient's pain improved and the patient's thickness of plantar fascia also improved. Like this. And we also apply our new treatment to the chronic inflammation of prostatitis, chronic prostatitis. And we reported this 44 cases data of chronic prostatitis. The chronic prostatitis is a very common cause of male genitourinary pain. Let me give you one example. The 48 years old male, 10 years history of genitourinary pain and lower urinary tract symptom, including the pain, burning sensation when sitting and urination, and difficulty urinating, and the painful ejaculation. So there is a NIH consensus classification system for prostatitis. There are 4 categories. Category 1 is acute bacterial prostatitis. Category 2 is a chronic bacterial prostatitis. And category 3 is a chronic prostatitis and chronic pelvic pain syndrome. That is the most common. And this case is also the category 3. Category 4 is without symptom. So there are lots of male patients who have sitting pain and urinary and this urination and pain, but there is no evidence of bacteria. So the most of patients have chronic prostatitis, and there is no other good option for this. And this is a diagnosis of chronic prostatitis is 2-glass test and negative. The result in this case was negative, so he doesn't have a infection, and also NIH score. The present case was 37, and there is NIH CPSI is a chronic prostatitis symptom index, and higher than more than 15 is a diagnosis, and the present case was 37. So chronic prostatitis has a high incidence, low QOL, and the impact of quality of life is similar to that of myocardial infarction, angina or Crohn's disease. And the low cure rate, those drugs are not useful in many cases. So go back to these patients. We plan, these patients already received many medication, but not improved. So we plan to do the embolization treatment from growing puncture and bilateral prostate artery angiography and embolization using independent. And this case, and we reported good results. For example, this case, the NRS, pain NRS, reduced after the embolization from 7 to 5 and to 0, and the symptom score also decreased dramatically. So this case was very good case, and if you want to see the results, you can see from this paper. So this is. So I will stop my talk, but I want to introduce you that we are now planning to run the international pain embolization congress, T.A.M.E Congress, International Congress in Tokyo in the next year, November not this year, but next year, next November 7 to 8. It is held in Tokyo. And this meeting called BnG meeting. The BnG means the vascular therapy and nerve intervention targeting inflammation and pain. So we deeply discuss about the pain procedure for joint, the knee OA or sports injury or frozen shoulder, and also chronic prostatitis. And we also discuss about hemorrhoid embolization or UAE or PAE for this session. So if you are interested in, please scan this QR code, and we will send you the information. And I will also go to New Delhi in next month, and this year December. I will talk about pain procedure in the CDAP meeting. That's all. Thank you very much.
Thank you, Dr. Yuji, for sharing your experience, and really it's a wonderful experience, and I always share your thoughts with my partner, Dr. Rosil Gandhi, that it's very, very difficult to find the unique treatment. We can copy your treatment, we can use your research finding to our patients, but primarily when I think I have to invent such a great treatment, it's a different ball game. So thank you for our invitation to join us in this conference, and really we are thankful that we are here. Thank you.
Thank you very much.
Thank you. Yeah.